Afternoon. I'd like to call the Health and Human Services and Aging Committee meeting February 3rd, 2016 to order. Can we have a roll call, please?
Calling the roll, Mr. Jones. Mr. Jones is absent. Ms. Conwell?
Here.
Ms. Brown?
Here.
Mr. Schron?
Here.
Mr. Miller?
Here.
We have a quorum.
All right, and I'd like to, even though for committee meetings we do not have to have an excused absent, I would like to make a motion to excuse Councilman Jones. All in favor say aye. Aye. Councilman Jones is excused. Anyone signed in for public comment related to the agenda?
No, Madam Chair, no one has signed in.
All right. Approval of minutes from the January 20th meeting. I'd like to have someone make a motion to approve the minutes.
I so move.
First and second, all in favor say aye.
Aye.
Meeting for January 20th minutes have been approved. There are 2 items that are referred to the committee today, as well as a presentation. Mr. Corlett will not be expected to be here until about 1:30, so keep that in mind. Chrissy, if you could please read the first item into the record.
Resolution 2016-0033, authorizing an amendment to contract number CE 1300529 with Wood Services Incorporated for residential services for the period 10/1/2013 through 6/30/2015 to extend the time period to 6/30/2016 and for additional funds in the amount not to exceed $575,000.
All right, and who is here to speak to that item?
Good afternoon, Daphne Kelker, Division of Children and Family Services. The Division of Children and Family Services is requesting an amendment to a contract for the Woods Services. At the time of the justification, there were 2 kids placed with this facility, which resulted in an increase in services and cost. The amendment is for $575,000. One of the children has since graduated and transitioned into MRDD, so the cost of the contract will go back down. The reason for the delay for the contract, we had some negotiations because there is MRDD involvement. One of our things that we were charged to do was to get ownership on both parts. And since we have an agreement with MRDD, where they will assume financial responsibility for children in our care that have MRDD involvement, it's at 50%.
So to my understanding, you said Ms. Faulkner?
Kelker.
To my understanding, you're stating that this certain contract is an amendment to increase.
Correct.
For 2 individuals.
We had 1 child placed there. We placed an additional child there. That's why the increase of the contract.
And could you tell me some of those things that $575,000?
The original contract was for $210,000. That was for the 1 child that was placed. This is a special care facility. The Woods, one of the children is severely autistic, and the other is, of course, MRDD and has some other health issues, physical issues.
All right. Any questions from the committee in regard to this?
I have some questions.
Councilman Miller.
Is this additional funding budgeted, or is it going to require use of HHS levy reserves?
It is HH levy. Again, like I said, we are being reimbursed at 50%. It was also budgeted. This process began in 2015, but because of the conversations and negotiations, it was held up.
So you're saying there's sufficient money in the existing budget to
Absolutely.
cover this? Okay.
Yes.
And we get these cases, they come in the Board of Control for time-sensitive, mission-critical. My question is overall, how many of these children do we have that have these special care needs with very high costs? How many do we have throughout the system, and how much is it costing us?
I can tell you, because I do present before BLC to you, probably 2015, I want to say, which was an increase, whereas we would have maybe 1 or 2 a year, most often 1. We probably had about 12. We lost one of our providers that handled more troubled children or children with physical or mental disabilities. In doing that, we had to find placements for those. And some of the placements, unfortunately, that we first considered did not work. We had to move the children around. For the most part, they are stabilized. Just the kids that are placed here, these children are stabilized also.
And do we have an overall strategy for how we're going to serve these children and how we might hopefully be able to reduce the cost and maybe anticipate some smaller problems before they become big problems? How are we dealing with this from a strategic perspective?
So the disadvantage for 2015 is finding placements for some of these when we go in on the front end. And I will say that our program people, they do negotiate. A lot of times these rates are increased. They could be more. But it's obviously easier to negotiate on the front end when we're procuring a new contract. It's kind of like they're at, we need them. But they do make every effort to negotiate the rates for these children. Mm-hmm.
Madam Chair, if I may, Thomas Pristo, Director of Children and Family Services. Councilman Miller, you asked about the not the streamlining of costs, but how does the cost affect this, and what's our strategy for that? That was why this contract was initially held up, because Kelly Petty and I were negotiating for them to take a more active role in providing dollars towards these children prior to their 21st birthday or their 18th birthday, and we were successful in doing that. They are going to reimburse us 50% for this particular child, and we will bill them every quarter for that reimbursement. Whereas before this amendment today, there was zero reimbursement from DD. So it's a small step forward. We're working with the Adams Board and with the court to help align this process a little bit more, streamline this process a little bit more than it has been in the past. So that's why this contract amendment was late. It was my fault because I held it up so we can, Kelly Petty and I could continue our discussions and get to an agreement. And with our lawyers, we were able to finally get the contract through.
Since this contract has been held up, are you requesting that we pass it under second reading suspension?
Absolutely.
Yes, sir, if you can,
Yes.
if you feel that that's appropriate.
Okay,
Thank you.
Mm-hmm.
Any other questions? Councilwoman Brown?
I guess the question is, do we have any metrics or performances, any way to evaluate how they're performing on the services for these contracts?
So the providers are evaluated. The contracts are also monitored. All this is done internally before we procure or amend a contract. An evaluation of the services and the provider is required, and they're satisfactory. Like I said, the children are stabilized and they have interaction with their family.
Councilman Tron?
Thank you, Madam Chair. How many other clients are we serving that are in this 300? If you divide that by 2, roughly $300,000 per client. I'm not sure what the proper term is.
One of the children, the child that was initially placed there was $210, and $210,000. And as I stated, these are severely disabled children. They require special care, sometimes 24/7 care. It's not like we can't do a home placement with them. So this type of environment is more suitable to fit their needs.
But
there's one for $210, and then when we added the additional, it was increased to $575.
Okay, so, but I guess same kind of needs for both the children?
Both severely disabled, yes, but not identical, no.
Okay, and how many other facilities in addition to Wood Services would we have as far as availability to make a selection process? And I'm not trying to suggest in any way, shape, or form that price should be the driving factor, but I just wanted to know what options the county has in this vein.
Very limited. I want to call Director Bristow up. In the past, there were accommodations, and it's very difficult to place children with MRDD interaction. Like I said, we can't place them at home. There's no medical facilities for them. So we created the CM. We actually created a house to help accommodate some of these children working with MRDD.
We created, again, Thomas Bristow, Director of Children and Family Services. We created the Ashton Lane House, which housed up to, I think it was 4 to 5 severely disabled children and youth. They are starting to age out, and we're going to continue to use that house as more youth are identified with those same type of issues to go into that home. That was something we created, and it has actually internal, I mean, not internal, within Cuyahoga County. So we were able to save dollars. We didn't have to go to a more expensive process.
What are the ages of these two individuals?
The children referenced are less than 18 years old.
I'm sorry?
Less than 18.
Okay. And this would mean that facilities like Hattie Lorem and places like that would not be available, and it just seems hard to believe that.
What we're trying to do, Councilman.
Because this is if you subtract out the numbers, this means that this one child is $365,000 for care. That just is a number that's really kind of staggering.
Unfortunately, these numbers, these type of situations do exist, and we do everything we can to make sure that both the efficiency of services, but also that we look at the cost. But sometimes it's such a severe disability that, as Daphne said, it requires 24/7 coverage with a medical staff.
But places like Hattie Lorem are 24/7 with extremely severe handicap. Okay. And I'm not trying to advocate one place or another, but I'm just aware that there are a lot of really, really quality places, and I'm just kind of asking the question to myself: is $365,000? Are there other places that we would have options to?
We do currently have children placed with Hattie Lorem, and I'm not the program person who would have placed, but I can almost assure you that Hattie Lorem was considered and quite possibly, more than likely, rejected the placement. We do go through our providers, and they feel if they can accommodate them or not.
Okay, so they would have chosen not to take this?
Yes, absolutely.
Okay.
Yeah, and that's something we're dealing with on a service level, on why our providers are saying no when we're giving them millions of dollars a year. What do we need to do to strengthen their infrastructure so they can take these type of kids, so we don't either have to go out of state or we can keep them local. So that is something that we are in the process of working on. It's a slow, it's not going to happen overnight, but these providers are very good. They're very, but they've been used to doing business a certain way for a long time. And if you come in and you start to ask them to do things a little bit differently, it takes a while to have that conversation so they feel comfortable making those changes. We are absolutely making that. I meet with providers every month, all of them.
Okay, I just know I've been to their facilities and seen the challenges they have undertaken, and it doesn't sound as though anything you're talking about here is something beyond their scope of what they
They reject it, sir. I mean, we give them the names, we give them the file, and we sit with them, and they go no.
Okay. All right. Thanks.
Yes, I'd like to follow up, Ms. Faulkner, with the loss of. You said there was a loss of one of our providers, and that's why we have Wood Services. Who was that?
Not necessarily Woods. Councilman Miller was asking because for BLC, I've presented mission critical placements. Oh God, was it Parmadale? I think it may have been Parmadale. Please don't quote me. I can get the information for you. But they took youth with they're tiered. So they placed children on higher tiers levels, which were most often difficult to place in a home setting. So with their closing, we had to scramble to find places, homes and facilities for some of our youth.
Okay. So I'm very familiar with Parmadale. Just was wondering if it was maybe a provider just didn't want to do business with us, but it was basically that they closed. My other follow-up would be when these children age out and they're out of our responsibility, where do they go?
So one of the children, that's why I say the contract will be reduced again for the next fiscal year. When the child ages out, it's usually at 18, and they transition into a MRDD. MRDD assumes responsibility for some at 18 and some at 21 years of age. So one of the children has transitioned out since we started the justification for this.
Okay. And when these children come into our care, they're basically court ordered, aren't they?
DCFS custodies, yes.
Okay. All right. I have no further questions in regards to this specific contract. Any others? Hearing none, any additional information you'd like to share with us?
Be it.
All right. And I heard that you need second reading suspension, and that's pretty much the mindset that the chairman always has. So I'd like to make a motion to move this to the full council, second reading suspension. Is there a second?
Second.
2 seconds. All in favor say aye. Aye. Matter is referred to full council, second reading suspension. Thank you very much.
Thank you.
Chrissy, if you could read our next item into the record, please.
Resolution 2016-0034, making awards on requisition number 34374 to various providers in the total amount not to exceed $2,541,600 for family-centered supportive services for the period 2/1/2016 through 1/31/2018, as printed on the agenda.
All right.
Good afternoon, Daphne Kelker, Division of Children and Family Services, and I have provided each of you with, it's a two-sided handout, which briefly covers some of the information I'm going to share with you. In 2015, DCFS submitted requisition and buy speed for RFP for family-focused community-based services. The targeted population was for families with children ages birth to 18 years old, families with children with special needs, and children who've experienced trauma such as physical abuse, sexual abuse, and or neglect, and families with parents who have special needs, mental health, or developmental disabilities, or families with open cases or DCFS custody or non-custody. The specific services requested were for children and family-focused preservation, which includes intensive in-home services, family in need of services, parent-teen conflict services, and reunification services, as well as resource family support. Additionally, we requested for evidence-based programming, which included parent-child interaction, which is also known as PCIT, trauma-focused cognitive behavioral therapy, TFCBT, and alternatives for family, which is a cognitive behavioral therapy, also known as AFCBT, supported visits and nurturing parents. The contracting period is for 2/1/2016 to January 31st, 2018, for $2,541,600,000. How can I help you? Do you have any questions for me?
I have a question.
Sure.
I looked at the backup information in the council meeting book, and I looked through the evaluation level for each of the agencies, and there were 5 possible levels, and every agency was rated as average, which is the middle of the 5 possible levels, and that just seemed hard to believe. That I just got to expect that some would be above average, some would be well above average, some would be only average, and maybe a few below average. But to have every one of them checked off at the same level, that raised a red flag. And I'm wondering if you could say a little bit more about how those evaluations are done and how those ratings were arrived at.
You're speaking in terms of the evaluations of the proposals that were submitted?
Yeah, in the council meeting book, they had each agency, and they had an evaluation summary. It was one of 5 levels. It was superior, above average, average, below average, or totally unacceptable, or something like that, and everyone was rated as average, and so I'd like some elaboration about that.
So if you're speaking in terms of the proposals that were received in evaluations, in talking with the program staff, one of the concerns, what we did with these services was unique for this contract. We created a master contract for all of these services because they're usually referred within a basket together. Some may coordinate with others or their service cumulatively. And they felt that maybe there may have been some concern with trying to submit proposals for all of the services or not understanding if this is what you specialize in. And some did. And when we pulled the pieces from each provider, if you notice, some of the providers are providing some of the services and some are providing others. And that also is based on past history with the providers, which is also when under the chart where I say the appropriations were based on provider capacity and past utilization. This is how we've utilized these providers in the past to provide specific services. That was the only, when we asked about it, is maybe there was confusion. And we have had that problem merging some of these services into master contracts. People are concerned how to respond.
Madam Chair, I appreciate that response, but it doesn't seem responsive to the question. The question I had is as to how the evaluation was done that resulted in the ratings that were presented in the backup information along with the legislation in the council book, and why it occurred that each of 10 or so agencies all got the exact same rating.
Two separate things going on here. One is the evaluation for the proposal that were for this contract. The other is what you're talking about. In the legislative book, I believe there was an evaluation that you said that all were average on all these different providers. The short answer is I don't know why all were rated average. The little bit longer answer is that in 2016, we are completely revamping how we assess and evaluate all our providers, which up to this date has not been acceptable. No fault, no blame anywhere, except that we have no standardized way of looking to our providers and saying, how much did you do, how well did you do it, and is anyone better off because of the service you provide? Those three questions are not answered in any of our contracts. That's going to change this year as we go through a process. And again, it's a conversation with the providers so that we can make sure that they have the ability to make those type of changes so we can review them. But you're absolutely correct. Having average for everyone is unacceptable because not everyone is. You're going to have people or providers that are above, you're going to have some below, some that are average. So that's our mission for our strategy, for our strategic process for this year, Councilman, is to have that resolved so that we can get a better assessment of the services provided.
Thank you. Second question is that this contract was supposed to go into effect on 2/1/2016, which date we're already past, and my question is whether that's resulting in any lapse of services, or is there money remaining in this contract so that continuity is available?
The continuity is available. The majority of these services are Medicaid eligible, so we push those services do continue with the families. This is the 2/1 is a result of an amendment that we did, and there's a quasi agreement with the providers. If the child is already in process of receiving services, that is continued.
And are you requesting passage under second reading suspension?
I'm requesting passage under second suspension, yes.
Councilman Schreyer.
Just strange that, at least if I understood the comment, that you have no knowledge of the scoring and and we will start a new scoring method next year. Is that with next year? Is that?
I didn't look at the legislative book, so I'd have to look at it to see, to refresh I'd have to look at it to see what Councilman Miller's talking about. I did not review it, so I don't know the scoring process that he's referring to. But having all providers having average is not, thank you.
All right, so next year we are starting with a different system. Tell me about the system as to what its effectiveness and what it's going to be measuring, because the way I understood your comment was you don't have good solid metrics to be evaluating these service providers.
We don't have good solid metrics across the county standardized in order to evaluate our contracts, and in HHS we have the largest amount of contracts. The new hires that just came on with the county executive, between he and I and some other folks, we are designing a standardized way to look at our contracts so we can determine whether or not the services provided are meeting the needs of our kids and families.
That gives me some real pangs of concern as we sit here getting ready to spend $2.5 million of the county's money. Why should we support the names that are on this service provider list if you don't have good metrics?
There's metrics in there, but they're not standardized across the county. There's not the same template for all the different providers. So depending on who's writing the contract, you may have different metrics that look at different things or different processes, but they don't tie in together across the board of our department or across the county. That's what I'm talking about. Every contract is evaluated, Councilman, but it's different depending on who the provider is and what the contract deliverables are. There's not a standardized way to really come to you and say, across the board on X million of dollars, we are receiving the services that our families and children are getting above average or below average service. There's not a standardized way. Every contract by our own policy and protocol by the county has to have some metric in it. It's just that it's not standardized. That's the part that gives directors kind of heartburn, is that we have no way to have a standardized template with individual indicators to determine whether or not what we're doing is making a difference in a family's life.
But what you're asking this council to do is to take every one of these service providers, put them into a single contract, say that you have basically said they are all working off of the same standard because it's a single contract to which we are appropriating the funds. And you're asking us to vote on that, even though it sounds to me as though you're a little uncomfortable with your own internals.
I'm not uncomfortable with the internals because I think that it's not because I don't think that they're doing an appropriate job. It's just that I can't validate that, and we are going to do that this year. We do have metrics in place in order to determine the type of service and deliverables, but it's not standardized. And I've talked to I've mentioned that before in a number of my presentations to the council.
But if you can't validate it, what you're asking 11 of us to do is to validate it by the fact that we are actually sending the monies to these service providers.
Let me change the syntax. What I'm saying is that I would be responsible for making sure that based on this contract that we will deliver the service, that the service will be delivered as appropriate, and over the next year we will have a better system to validate it. I have confidence in these providers. Everyone's trying to do the right thing. There was just no metric available consistently in the past years to develop this.
So you couldn't sit here and tell us that service provider 1 is doing a better job than service provider 7, which is doing the worst job is service provider 10, for example, based on your independent criteria.
So the selection by the program staff is their experience in regards to service. That's why when I stated how that money is allocated, some providers do excel in some things and some aren't as strong. But all of these programs are evidence-based programs in the sense that they have a proven track record for the deliverables that we've requested and to address the targeted population. When we say average,
maybe I'm not trying to wordsmith it, but perhaps I'll give you an escape lifeline there. Instead of saying average, is it acceptable level of service? Is that a more appropriate way, that they have met the minimum threshold?
If we didn't believe they're doing the level of services that our children need, we would not be contracting with them. We would not be using them at all.
Then what that does is it opens up the dialogue for me as to why is one selected for $140,000 worth of services, another one selected for $580. If there's not some kind of criteria as to one's doing a better job with X and Y, or maybe it's they don't even have that service. Educate me as to. Okay, I will walk off of the selection of the names, and now I'm going to walk into the dollars.
Okay, so each provider.
Tell me why the dollars were selected for the.
Okay.
Because we've been here for 5 years, and I'd be willing to bet if I go back to 5 years, I will see every one of these exact same names for the last 5 years, which means that not one of them has been knocked off.
That's not true.
Well, no, I'm asking you. Tell me whether these names, if I go back, will all these names show up on service providers?
Some will, yes, because they do. I mean, let's just give an
Tell you
example.
what, provide me with the ones that are new in the last 5 years before we vote on this at our next
I
meeting.
can get that information for you.
That'd be great.
I'm not aware of.
Thanks.
Okay. But what I want to also explain is some of the providers where you see the larger dollar amounts, they may provide of the services that we're procuring. They may provide anywhere from 2 to 5 of those services. Some of these providers only specialize in maybe one. They may just specialize in nurturing parents or supported visits. Guidestone is primarily, we use it for supported visits. Beachbrook serves a larger population and they offer a larger package. One of the other reasons where they may or may not service or provide those services, one of the issues we had was they don't have the properly trained staff. So they won a contract, they submitted their proposal for the services that they are able to offer.
Okay, I can understand if somebody doesn't provide the service, why they wouldn't be included. I can understand why if somebody's doing a better job, they wouldn't necessarily be included. Is there any competition where there's common services provided by multiple individuals on the service providers on this list, and then you had to make a decision, hey, I want to use firm A versus firm B. They all provide the same service, and then you get down to who got the dollars is what I'm trying to.
Quality control, you talk about what quality does provider A versus provider B of the same service? What's the
they both provide the exact same service. And then you chose to set dollars, just looking at this list, I'll pick items 1 and 2. One got, let's assume that the first two can provide the exact same service. One's getting $581,000, the other's getting $269,000. How and why was that decision made?
So when they submit their proposals, we have a team of staff that evaluate the proposals, and we did reject probably 4 proposals. These were the winning. As a matter of fact, to ensure that we received full representation, we did a second evaluation of the proposals. So this is based on what they submitted. It has nothing to do with their past history. The people that I have evaluating these contracts are not necessarily the users of these programs. It's based on the information. We meet with the providers and have discussions with them. So.
Okay.
But to answer your question, if we have provider A and provider B doing the exact same service, do we have an evaluation that looks at how well they're doing?
Back to Mr. Miller's question.
Right.
Why would you have selected A versus B if they both provide the same service? And then why would one have gotten more money than the other to provide those services? What's the underlying decision process that would have gone on?
We can add location also.
Well, there's a couple things. Location of where that provider is may influence giving that contract, depending on the county. But to be honest, looking at if we have two exact same providers or two providers providing the exact same process, I'm not sure where in our system we have or whether we ever said A is going to get it and not B because A does a better job than B. I can't answer that right now. I have to go back and check. Okay,
well, I'd like to see that because, I mean, let's face it, we hope that competition improves quality and quality then improves performance out there. So, well,
look, and I'm not, one of the reasons why I was hired in this position was to do exactly what you're saying, is to make that standard, to have an evaluation process that we can go back to see how well our providers are doing. To do that takes some time and it takes providers involved, and we are going to, that's what 16 is about, 2016. So I'm right there with you. I'm just not, I haven't had 15 years here to know the history of all the providers and all the different processes we go through, but we are absolutely committed to doing exactly what you're saying and providing a way for these providers to make sure they are doing the best service possible for our kids.
Because this is such a significant amount of money that we obviously spend in this area, it's one of our most critical things we do as a county. I, as a committee member, would love to have the information, because we're looking at evaluations within economic development of competitiveness. We're looking at it in other venues. This would be very positive way to tell the county how and why we're getting the best services for our dollars. And if you could provide us with that criteria as it's being developed, I would really welcome that. Thank you.
Yes, we could.
I have a follow-up. Councilman Miller.
The follow-up is that in the backup materials there was a summary list of all the agencies, and there were two. The first one, Applewood, and the last one, Centers for Families and Children, that were not given contracts. And my question is why were these not given contracts and the others were given contracts, and also were these two funded in the previous round, or were these new applications that we didn't add to the list?
We previously done business. They were considered non-responsive when we evaluated their proposals.
Were they in the previous? Were they previously
Yes.
funded? They were.
Yeah.
And can you give us some sense of on what basis they were non-responsive?
So there's certain criteria. We request certain deliverables in regards to their model and how they deliver their services. And they're rated, the score, I want to say 75. The passing score for this was a 60, maybe 66 or 63. And they scored below. So like I said, some of these we reevaluated and looked at them again, and those two were definitely non-responsive. And I can't think of the criteria.
Now, by non-responsive normally means that they didn't answer some of the questions.
Absolutely.
But you're saying, is it that, or is it they were evaluated and found that their overall score did not meet the cutoff score?
The overall score did not meet the cutoff score, and it could be due to not answering something properly.
Okay.
Councilman, you finished? Thank you. Okay. Just to follow up on, currently we have limited numbers of the providers providing these type of services. So my concern is we should have a metric system, but if we currently have a limited number of providers providing these type of services, are you taking that into account when you're going to make this metric system? Because you have a limited number.
Absolutely, this is one of the criteria.
These are kids that we have to take care of, and we have to make sure that they meet services. Now, this particular contract is just for family outside services, right? It's not.
They may or may
in-house.
not be in county custody. Yes, they may. Some of the
So it's a
services
mixture
occur
of
in the
both.
home. Yes, in the community, in the home. They're not necessarily DCFS custody.
Okay, so this committee would definitely be interested in how you're going to balance that. And also if you can provide us currently with a list of all the organizations in the past or all the service providers that we've had in the past, so we can see what numbers that we have that can deal with these certain situations. And I do remember from previous committees, this question has always been answered in regards to the dollar amount. So I fully understand that it depends on the number of kids, the availability that they have, the type of services. So that's why the dollar amounts always fluctuate, because the child is placed based on what their need is.
You're right. And another thing that, when we submitted the RFP, we bare bone this in regards to basing it solely on max utilization in a sense, and I believe the prior contract was almost close to $4 million. Some of those funds were underutilized, and we've taken a chance that if we do get to where we get close to where we feel we're going to, I don't have a problem coming back, but we've been utilizing these services for well over 20 years. And as I stated, it's a community service. The primary focus is to keep some of these kids from coming into our care. We are working on with our performance management unit in regards to the metrics and how we track these things and ensure that we're receiving what we're paying for, number one, and suiting the needs of the children that we and the families that we service.
In the past, and correct me if I'm not understanding correctly, but take the Blair Foundation, for example, and over $269,000. At the end of the year, if children weren't sent there and those dollars weren't utilized, they come back at the end of the year to us, correct?
Absolutely. Then there's also the uniqueness of the master contract. We can't guess what type of services our community is going to need. The master contract allows us to pool this money. So if Bear is underutilized, we can push that over to another service provider, another service, which is why we're moving to the master contract model.
Okay. So I was correct.
I mean, Bear, you're right. Bear may not spend a penny of this contract.
So there's still an issue, I know there's a limited source of providers, and I understand that, but I am still, I guess, brought out in this committee concerned on Councilman Schron's point in regards to how are we going to set a matrix, because I know I've sat on this committee since inception, and I remember Applewoods and all these others, and now they're not in it. So our concern is if Applewood, the big corporate agency, didn't make it on, and I'm not, advocating for Applewood, just using them as an example. If they didn't make it on this particular service contract, then there needs to be some reason why, a metrics or, whatever that case may be. And so we just need to, I know you stated that, they didn't fill out their particulars or whatever the case may be, but, just in any instance, we need to be able to validate why we're not utilizing another organization or why one is better than the other or performing better or whatever the case may be. And I know this is not an easy topic or easy situations or easy lives to deal with, but we do want to make sure that the money is efficiently spent, as well as top priority, the kids, their needs are being met to the fullest extent. So any other comments? Councilman Schron.
Yeah, I'll just make a comment. I'm sorry, but 20 years doesn't mean anything to me. I'm sorry. Other than the fact that you've got a 20-year history, it doesn't necessarily mean that the quality of the service was done there. I hope it was. I trust that you're doing your job, but that by itself does not automatically mean that this year's service is as good as what we expect it to be for our kids. So unless we're actually monitoring what they did 19 years ago, is not as relevant as what they did last year, and how they're going to go forward this year. So that I just raise that as the point. And when the director says that by this spring we're going to have criteria and measuring and being able to analyze that, that's great. I know this is really an extension of an existing contract where we're just reapplying dollars for a new round here to these same service providers. But going forward in the future, I would really take the directors at his commitment that he made here, that we will have a standard, and it would be great to be able to look at that and have it in front of us, because let's face it, these are businesses here, and we want to be able to look anyone in the eyes that made a proposal and say, you lost fair and square, here's the reason, here's why, and these are providing services out there. And obviously, ultimately, the whole objective here is for taking care of our kids. Thanks.
Thank you.
All right, can I have a motion to move R20160034 to the full council second reading suspension?
I so move.
Moved and seconded. All in favor say aye.
Aye.
It is moved to February 9th.
you.
Thank you. I believe now we will have a presentation by Mr. Corlett. And I apologize, I didn't see you earlier, Mr. Corlett. I was just told 1:30.
I learn something every time I come here.
All
I'm
right,
not sure
so
how
welcome.
I turn this little thing on here, but Christina can help me. Thank you very much. Thank you very much, Madam Chair. I appreciate the opportunity to talk with you today. We wanted to give you a sort of a very brief high-level update on a Medicaid proposal that's pending, being developed at the state level. And it's a proposal, we call it a Medicaid waiver. It's actually similar. We did a Medicaid waiver when we did Metro Healthcare Plus. That was a Medicaid waiver as well. So I just want to talk about where we stand in terms of the Medicaid expansion in the state as it relates to Cuyahoga County, and then sort of run through this proposal. Prior to 2014 in Ohio, low-income childless adults and parents above 90% of the federal poverty level didn't qualify for Medicaid. But after the Affordable Care Act, those groups became eligible for coverage if they had incomes up to about 138% of the federal poverty level. And so statewide now, that's about 640,000 people who have enrolled in the program, which is actually a much larger group than anybody expected, larger than the governor projected and larger than outside groups. And in Cuyahoga County, we've got probably about 95,000 people who took advantage of that coverage expansion and enrolled under Medicaid. So,
Question on
yes.
that point, Councilman Miller.
Is this all children, or is this children and families?
To the chair, Councilman Miller, no, this is adults. So these are just adults that were newly eligible under the Medicaid expansion through the Affordable Care Act. So there are no children included in this category.
All adults.
All
okay.
adults.
Okay.
All adults. Yep. So over the course of the budget, this last state budget, when it was passed last spring and signed by the governor last June, a proposal was added that requires the State Department of Medicaid to apply for this waiver. And a waiver is really, you're asking the federal government for permission to waive certain Medicaid rules. So this waiver would require all non-disabled adults on Medicaid who currently qualify, so the newly eligible folks and the parents and adults who were on previously, to pay premiums into a health savings account. So this would apply to about 1.1 million adults, Ohioans, who are currently enrolled in Medicaid. So it's a really large number, because I think the total caseload now of Medicaid is around, I think it's about 2.2 million, 2.4 million. So this is roughly half of the people who are in Medicaid would be required to pay into these health savings accounts. And so the table just sort of shows you, what those other categories are. So to Representative Miller's point before, you can see I don't know if you have the colors in front of you, but the light blue is the kid category. So children in Medicaid are about 1 million. They make up a large share of the caseload. But for adults, this would affect most of the adults on Medicaid to enroll in this waiver, about 37% of the overall Medicaid enrollees. It doesn't apply to aged, blind, disabled, and there are some other categories of Medicaid that it doesn't apply to.
So stop on that point.
Yep.
So everyone that was on the Affordable Care Act, since it got instituted, the people on Medicaid numbers went up.
Correct.
And so those individuals now we're going to require all of them that are non-disabled to, based on their income, put money in the HSA?
Yeah, so I'll get to that. Yeah, so there's a limit on how much they have to put in, but it would apply to largely every adult who's on Medicaid in the state who's not disabled, and it doesn't apply to children. But for almost every adult who's on Medicaid in the state, whether they qualified under the expansion or whether they were previously on the program, would that now be required under this proposal to put money into a health savings account?
So I'm taking it that those Medicaid individuals are ones that are employed and not the ones that are not employed.
No, they would not necessarily have to be employed. So under this proposal, for example, there's no exemption if you're unemployed. There's no exemption if you're homeless. There's no exemption if you don't have any income. Everyone is required under this proposal to put money into these health savings accounts.
So if you're homeless, how are you able to do that?
That is a good question. Now,
I mean, there are homeless that have some retirement funds or SSI or something like that, but then we do know that there are individuals out there that don't have anything. They're totally indigent, and so those are the ones that I'm totally concerned about at this juncture.
Yeah, there's no exemption. The proposal does not envision an exemption for those individuals.
Okay, I'll let you continue. We're going to chew on that.
Thank you. So I just want to talk a little bit about the process, about how this sort of happens. So the Department of Medicaid first has to draft this application to the federal government, and we're expecting them to release that draft in the next couple of months, so probably March or April of this year. Once they release it, they have to allow 30 days worth of public comment. And they have to hold at least 2 hearings in the state where they accept public comment on the proposal.
Can you keep us updated on when that is?
Absolutely,
Thank you.
Once they've gathered that comment, they can then submit the waiver to the federal government, to CMS, the Centers for Medicare and Medicaid Services. And then CMS, once they get it, they allow a 30-day public comment period as well, and that applies nationally. So because a lot of this is really probably there's a lot going on in Medicaid around the country with these various waivers. This would really be pushing the envelope, and so there'll be a lot of national attention on this proposal. They have a minimum of 45 days to make a decision. That would be very unusual if they made a decision in 45 days. Just to remind folks, I mean, it took us to get a decision on the Metro Health waiver. That was a year-long process. So there's a lot that goes into this. This is a very complicated proposal, and so I think it will take some time for the federal government to review it.
And still on that point, if we have 30 days of public comment, I'm assuming that they're going to actually look at that public comment across each state line, and so wonder if they determine, there's sort of a consensus in that public comment. Are they willing to change like one of these things that we're not in agreement with?
So Madam Chair, 2 comments about that. One is, once they receive the public comment, once the Department of Medicaid receives that public comment, when they submit the waiver application to the federal government, they have to show what the comment was and show how they responded to it. So that's one point. The second point is, the requirements for this waiver were spelled out in state law. So the state, the Department of Medicaid, the governor's office, doesn't have a lot of flexibility to negotiate on this because it all got put in statute. And so in a way, their hands are somewhat tied over some of these things that we might have objection to or be concerned about, the issue that you mentioned, for example. So I think the complicating factor about that is that may make it easier for the federal government to turn it down. But this being an election year, I don't take anything for granted in terms of how things might play out or how things might be viewed. But the administration, I should say, the governor's office and the Medicaid office, their hands are somewhat tied on this because the legislature has said, you shall go seek this waiver, it shall have these elements in it. And that's been the position of and I think to the administration's credit, from their perspective, the legislature passed this, told us to do it. We're going to do it in good faith. We were going to submit it in good faith. I don't think it was something that they supported originally. It certainly wasn't something that was in the governor's as introduced budget, but it was something that was added through the legislative process. Originally it was actually, the first proposal actually included kids too, and we got that at least taken out because that just made no sense to have children pay premiums into health savings accounts.
Councilman Miller?
Yes.
Madam Chair, who dreamed this up?
Madam Chair, Councilman Miller. So this, I think when folks, when the legislators who proposed this first talked about it, I think they were trying to model it after a similar waiver in Indiana. So Indiana had a waiver, but the difference with Indiana was, one of the differences in Indiana, so let's say, to the chair's point earlier, what if you don't have any money? what happens. So in Indiana, if you don't have any money and you can't pay the premium, you get switched into a Medicaid, sort of what I call Medicaid Light. It doesn't include all the benefits of Medicaid, but you get the core services like hospitalization and doctor visits and durable medical equipment and lab tests and all that kind of stuff. But in this Ohio proposal, they didn't do that. They just said, if you don't pay, you get kicked off the program. So I think originally we're trying to model it after Indiana, and then I think they went a little farther.
Well, it seems obviously discriminatory toward poor people and contrary to health care policy in this country, which is supposed to be moving toward universal coverage. How could the federal government possibly accept this?
Well, to the chair, Councilman Miller, the federal government has approved elements of this before already. I mean, in other states, and where they've done it, Councilman Miller, is really in states where there was not the support to expand Medicaid. So it was a compromise in those states. They'll say, well, we'll let you charge premiums to certain people, or we'll let you do some of these things, but they've never done all of this before, and they've never said that, particularly for people below poverty, that if you aren't able to pay the premiums, we're going to take away your Medicaid coverage.
And good public relations people as they are, they put a name on it. They call it Healthy Ohio. It's probably actually the opposite of that.
I would tend to agree with you. I'll keep going here so I don't. So we've talked a little bit about this before. It's charged, the premium, who pays, is charged to all non-disabled adults. There are no medical exemptions. For example, there's no exemptions for people who are medically frail, for those with mental illness, for other people. No exemption for those with zero income. So the one point I do want to point out is, and it does set a limit on the premiums. They're either equal to the lesser of 2% of your income or $99 a year. It does allow third-party organizations to pay a part of the premium. So let's say a Metro Health Hospital, for example, could say, well, we will pay, but they can only pay up to 75% of the premium. So it could take the cost of the premium down for folks. But they have, under the law, they are obligated to pay some portion of the premium themselves, putting aside how they'll ever keep track of that. But that's a whole other issue. So how do you lose coverage? Who can lose coverage? If you go without 60 days without paying your premium, you get kicked off Medicaid. You can't come back on the program until you paid those back premiums. You can also get kicked off for not completing your paperwork on time. The one group they exempted from being kicked off are pregnant women. But once you deliver, if you haven't paid your premiums, you then can be removed from the program. So one of the things, a lot of people, well, and to Councilman Miller's point earlier, where has this been tried? It's never been tried exactly in this way, but before the Affordable Care Act, Oregon adopted a similar plan with premiums, with no exemptions for zero income, and they kicked people off for not paying. And so after a 2-year period, about 77% of their enrollment dropped off the program. So over that 2-year period, as people had to pay these premiums, people dropped off the program and lost their coverage.
So on that point, what happens, even though they chose to drop off because obviously they couldn't pay, are they in any kind of trouble for the premiums that they weren't able to pay before they dropped off?
So, Madam Chair, in Oregon, they were not. I will point out that CMS just approved a Medicaid waiver from the state of Montana, where the people who are obligated to pay premiums now in that state, if they don't pay them, it becomes a debt to the state. And so when they go to file their taxes, if at some point they do have income, the state can then take that money that they owe for those back premiums. So they have been allowing that, but that's the first state in that example. But so what they found in Oregon was that people had higher unmet health care needs, they had reduced use of care, more medical debt, greater household financial strain than individuals who stayed on the Medicaid program, which makes sense. I mean, in terms of if you lose your coverage, you often lose your access to care.
Madam Chair.
I had a same. Go ahead, Councilman Miller.
Other than by knocking people off the program, is this supposed to save them money somehow? I mean, it seems extraordinarily burdensome and costly to administer. I don't see how they save any money on it other than by it being a way to kick people off the program.
Madam Chair, Councilman Miller, I think you're right. I mean, yeah, you know, I just want to say, you know, the beauty of what Ohio did was they kept it simple. You know, I mean, because the more complex you make things, the costlier it gets. I mean, I'm not even going into all the details. There's other details around this that will increase costs for the program. You know, more IT costs, more requirements of the managed care plans, things that they have to do. And, you know, one of the things about the expansion to remember is the federal government pays almost, at this point, 100% of the cost, but at one point they pay 95% of the cost. All these administrative charges, Councilman Miller, the federal government only reimburses at 50%. So it not only increases those costs, but the state is on the hook for a larger share of those costs. And I just also want to point out other examples. In Arkansas, they recently eliminated the imposition of health savings account and cost sharing requirements on participants below 100% of poverty because of the high administrative costs. They were spending more to collect it than they were collecting, and so it made things more complicated. And then Virginia implemented a $15 monthly premium for each child enrolled in Medicaid with families above 150%. And then they ended it when they found out that they were going to cut 4,000 kids off of the Medicaid program. It was like, we don't want to do that, and so they brought it to an end. And they also found that they spent $1.39 for every dollar that they collected. So one of the things to think about is what would be the impact on Cuyahoga County. And so I referenced earlier, you know, that we have 91,000 people who've enrolled just through the expansion side, not from the folks who were already on Medicaid, the adults already on Medicaid. You know, if we had a reduction similar to Oregon, that would mean 70,000 people losing their coverage and becoming uninsured. And so the effect on the Metro Health System, on the federally qualified health centers like NEON or Neighborhood Family Practice, you know, mental health agencies would be dramatic. It would wipe out nearly all the financial gains that those institutions have experienced from the Affordable Care Act. And I think the other thing to remember too, and to getting to your point, Councilman Miller, the complexity this brings, think about the churn that this produces in your own JFS office. Somebody comes on, they go off. They come on, they go off. And the time that is spent in processing those cases can be very time consuming. We have an example of that just last year when the state was set to terminate a bunch of people from the program, started to terminate them from the program because they hadn't responded, and then pulled back from that because of, you know, issues around the paperwork and stuff. And so the agency here, your JFS agency here, was moving to take everybody off, and then they had to sort of change course and move to keep everybody on. And so that doesn't sort of bring any, there's no value in that. And it's I think, a waste of resources. So to the chair's point earlier, you know, we expect the state to release a draft, you know, in the next couple of months. We're going to analyze it. We're going to participate in all the comment periods. We'll share that with you. You know, we'll keep educating people about this, making people aware of this, and let people know about what the potential effects would be. Because I think it'd be really destabilizing, not only for the families involved, but also for our institutions that provide health care in the community.
Well, this sounds like a big mess. We appreciate you coming and updating us on what's going on the state and federal level in regards to this Medicaid expansion, because I just think we have to do a better, we can't, like you said, it's in the statute. On a county level, we have some restrictions of how far we can push some legislation, but I think we need to do a better job of marketing, letting people know, well, if this goes into effect, what are the parameters? If you take it, what are the premiums about?
Right.
You know, what's going to happen if you don't pay the premiums and you take it? I mean, we need to really do a good job of that, so people don't find themselves down the way owing a bill.
Right. To your point, I mean, I think if this were to be approved and move forward, it would require a massive amount of education of folks, because we're talking about 1.1 million people. Yeah, that is a lot of people in the state.
And
That's
then
like 1 out of 10 citizens in the state.
And then we go back to the thought, well, if they don't sign up and we didn't have this Affordable Care Act, what did people do before when they got sick? They just went to the hospital. They were sick.
Yeah, it doesn't, that's a good point, Madam Chair. It doesn't, none of this reduces costs. The costs are still there. They just get distributed some other way. I mean, they either get distributed, you all provide a very generous subsidy to the Metro Health System. It shows up there. It shows up in people's private insurance because they pick a part of that uncompensated care. It gets stuck on everybody's bill, on everybody's insurance bill. So
hopefully they'll remember these things, and maybe during public comment we can help them with the decisions. But you basically said they're basically listening to us. Pretty much.
We have communicated with the state about this. I think. As I said, I think originally this was not their proposal. This was not a proposal of the administration. This was a proposal from the legislature, and so I think they're doing their best to be true to that. So.
All right, thank you. Any questions, Mr. Schramm?
Thank you, Madam Chair. The HSA provision within there, without getting into the rest of some of the things you commented on, is that retained by the individual like most HSAs are into an account specific for that individual?
To the chair, to Councilman Schramm. So under this proposal, so let's say, for example, your income moved above the limit for Medicaid, you would be allowed to take that HSA with you and apply it towards healthcare costs that you might acquire someplace else. So like, let's say your income moved above the limit for Medicaid, you'd be able to use those dollars in that HSA to help pay for your coverage that you might get through the exchange or maybe through an employer. Well, let's say you were offered you got a job and offered employer coverage. You would be able to use the money in that HSA to help pay your share of those costs.
But regardless of what your technique or what you want to use it for, it always is retained in the individual who made a contribution, regardless of whether they're using it for this purpose under the Medicare expansion, or whether they use it for retirement to cover drugs later on for a supplemental policy or anything like that. Is that
to the chair?
Every HSA I've ever heard of, it belongs to the individual. So I just want to verify that with this one.
To the chair, Councilman Chen, I'm not sure because because one of the questions I've asked is, it spells out very clearly like what happens if you like, let's say you obtain employment or you move out of the income eligibility, get your coverage for the exchange, how you could use it for that. But it's not, one of the things that's not clear to me about the proposal is, let's say somebody just decides to, kind of your point, well, this HSA is mine, and I'm going to just go off the program and I'm going to take that money. It's not exactly clear how that would work. But it's not exactly clear that they can keep it because the state's putting money into it as well.
Yeah, well, we have an HSA and we put money into it for our employees, right. and the employee puts money into it for themselves, and it is sacrosanct. It can't be touched by anybody other than the individual. So if they're using those terms, health savings account, I can only assume that it is not going to be touchable by anybody but the individual.
To the chair, Councilman, because the state, under this proposal, because the state Medicaid agency would be putting those Medicaid dollars into those accounts, I'm not sure if I would think about it the same way as the HSA that I have or that you have.
Well, what it is usually is there might be a vested provision that touches the dollars coming in from the state. But I can only assume the dollars coming out of their pocket have to always be 100% vested, and the dollars coming in from the company or state might have a 1-2-3 year vesting proposal that would go in. What is you didn't touch on any of that. Could you elaborate as far as what the state is putting in of matching dollars into this HSA account that's going in?
Sure. So the state,
you kind of, I didn't see that any place in your proposal. So
yeah, no, there's a lot more to this proposal. So the state, I think what they put in when you pay your premium into your HSA when you first start, the state will put in $1,000, and so then when you go to get medical services, rather than charge the Medicaid program, they charge your HSA first. Sort of similar in some respects, how a high deductible plan works, with a health savings account.
Okay. Comments on the concept of an HSA, good or bad in your mind?
I mean,
You have one, it sounds like, so you must
Yeah.
think it's good enough for you to use. So I have one, so I think it's good enough for me to use. So I
yeah,
like that.
it's just the cost of administering it, I think, and the complexity of it, because the Medicaid program, the way it operates now, is cheaper than setting up this whole new apparatus to do it. I mean, it has very low administrative costs. This adds a level of complexity to it that doesn't exist today. And these are folks who are, largely not employed. And so I just think it's a different population.
Let's leave the concept of the
Yeah.
cost out, because
Yeah.
my question was, do you think that an HSA is good for the patient? You think it's good for you. I think it's good for me. Tell me
Yeah.
what you think in regards to the
I
population.
don't think it's good. I don't think it's good for the Medicaid population because I think of the complexity it adds and the cost that it adds to the program.
No, that's the program. Go
Yeah.
back to the patient. Please just
I
stay
don't
with
think
the
I
patient.
don't think it's good for the patient either.
Okay, thank you.
All right, any other follow questions or comments in regards to this Ohio Medicaid waiver? Anything else you would like to share with us, Mr. Corlett?
No, thank you, Madam Chair. I appreciate the opportunity.
And we do thank you for bringing this to our attention. And I am sure that Chairman Jones is sorry that he missed it because he's going to need to know this information. I don't know if you have it on. You have it on tape
Yeah.
where we can leave for him.
Right.
And if he has any questions or
Happy to
anything,
answer. Happy to
you
help.
could fill them in. All right. Well, thank you.
Thank you very much.
All right. All right, where we go. Miscellaneous business? Any public comment related to the agenda or unrelated to the agenda?
No, Madam Chair.
All right. Meeting is adjourned. Thank you.